So from the obesity, the type 2 diabetes, from the obesity, the secondarily the PCOD, that is the polycystic ovary syndrome, and the secondarily CVD, that is the cardiovascular disease, atherosclerosis, osteoarthritis, last but not least the cancer due to inflammatory marker elevation due to obesity. So the prime culprit is the obesity because of all these parameters. And endocrinologically, primarily the modified lifestyle disease induced disease is caused by the disease is caused by insulin resistance. This term I wanted to reiterate, insulin resistance, because this is a center pin for our entire my 25 or 30 minutes of presentation. So what do you mean by insulin resistance? Will be normal, but the insulin is inadequate to produce the insulin response at the target organ. Normal insulin is inadequate to produce the insulin target organ. The target organs is three areas. One is primarily the adipose tissue, next one is the liver, and third one is the muscle. So though the insulin secretion is normal, I'm repeating, but there will be very poor response. So that is what is called the insulin resistance. So coming to our area, the obesity, before we see what is the metabolic obesity, that we have the broad spectrum of classification of obesity, general obesity. It is divided into two types broadly. One is the central obesity and the other one is the peripheral obesity. The central obesity is otherwise called the abdominal or apple-shaped obesity or the android obesity, android type obesity, wherein the energy store is in the abdomen and the waist. Coming to the peripheral obesity.
Excuse me, Prof. Prof, are you sharing your slides? Nobody can see the slides actually.
No. Just after 2 minutes, I'm going to.
Okay, Prof. Okay, Prof.
Because with this intro, I wanted to share the slide. Thank you, Atif. So the second one is the peripheral obesity. The other way of calling is the pear shape or the gynoid size, wherein the energy store is in the form of stored in the buttocks, hips, and thighs. That is what is called the BHD. So coming to my area of presentation, the metabolic obesity. There are, again, I wanted to say, what is the metabolic obesity means? The obesity broadly divided into, one is the physiological obesity and another one is the metabolic obesity. Wherein the metabolic obesity, the physiologically obese or physiologically non-obese doesn't matter, but metabolically a subject is obese. So this is the point to note down here. So the physiological parameters or the physiological markers like the anthropometric markers like waist circumference, BMI, waist hip ratio, that is what is called the WHR, etc., etc. And the metabolic markers includes the lipid parameters like TG, cholesterol, and the lipoprotein markers like VLDL, LDL, and the hormones that we are going to discuss now, and the pro-inflammatory cytokines thereafter. So with this, I wanted to go for the slide presentation. So just 1 minute. Can you allow me to share the slide, Dr. Atif?
Prof, you have to ask the host, Fahim. Fahim, can you allow to share the slides?
Still I cannot.
Yes, Fahim, you have to put Prof as a presenter, then he can share.
Still not locked.
Okay.
Now okay. Is it visible?
Yes, yes, Prof.
So this is about my title, Metabolic Obesity Essential Hormone. Uh, See, this uh, subject happens to be, we call it as the couch potato. Couch potato means with the minimum physical activity and the maximum calorie intake. So this is what is called the couch potato. And at one point, uh, she got a place in a obesity rehabilitation center to treat her disorder. Then the doctor was asking, there was a conversation between her and doctor, what is your problem? Then the patient, she was telling the problem is that my family runs with the obesity. Then the doctor says, no, the problem is no one is runs in your family. So this is only comedy come and some info to get. And why you are depressed, I eat, that is why I am depressed, because I am depressed. Why you are, vice versa, I am depressed because I am eating, or I am eating because I am depressed. So in that way. Then later on, she realized her errors and she wanted to do some aerobics or something. She wanted to cut down her excess fat. Then she turned around her diet also towards the diet and fresh vegetables and fruits. Then everyday cycling, that this activity gradually increased. Then finally concluded the weapon of mass destruction is this sort of food. So what is obesity? In general, there is a intake and the expenditure. Here the intake is more and the expenditure is less. That is the fact in terms of. So it is stored in the. So what type of intake we have mentioned here? The intake is the carbohydrate, protein, fat, and the expenditure BMI, BMR, sorry, thermic effect, physical activity, etc. etc. So the excess fat, what I mentioned in the previous slide, the excess fat will be stored in the adipose tissue in two different ways. One, it can increase the size of adipose tissue, or it can multiply the number of cells in the adipose tissue. So here this is the hypertrophy and hyperplasia. The enlargement is called the hypertrophy and the multiplication is called the hyperplasia. So these are all the general things about that. We need not spend time for explanation. What is the BMI? What is the overweight? And this is the scenario, rate of obesity incidence. And what is the craving for food? The temptation is see there are double or triple fatty nowadays. We can see in the McD or in the KFC or whatever. And the high calorie diet we prefer nowadays. These are all the reasons for obesity. And the couch potato in the beginning I mentioned, no. So no activity, only watching television and sitting in the car and working with the computer. So these are all the things to make one to become couch potato. So I told you in the beginning, the obesity is divided into apple type and the pear type. So this is what here it is mentioned. So distribution of fat near the abdomen area is called the android or apple type, and the distribution of fat near the buttock, hip, and waist. So that is what is called the gynoid or the pear obesity. So this is the the Android one or the Apple one is more dangerous than the gynoid because there is no significant correlation with the metabolic syndrome for the gynoid. So in terms of health risk, it is given here. Coming to the hormone part, here the function of ghrelin. I think some of you might not heard about this ghrelin hormone, which is secreted from the gastrointestinal tract, playing a crucial role in the obesity incidence. There are two hormones we have to see. One is the ghrelin and another one is the leptin. Ghrelin is favoring the appetite stimulation. So there will be hunger stimulation, means the ghrelin will be increased. And to reduce the hunger stimulation or to suppress the hunger, we need the leptin. So the hunger stimulation is favored by ghrelin and the hunger suppression is favored by the leptin. So with this intro, I wanted to say this ghrelin favors almost some 3 or 4 functions here, which stimulates the brain to favor increased food intake through the adipose tissue. And number 2 basic function is the ghrelin stimulates the adipose tissue to grow in size and number. That is what is we already saw in our previous slide, that hyperplasia and hypertrophy. So there also the ghrelin is favoring a crucial role. So in terms of hormone, the ghrelin playing a dirty role here to grow the size and the number of adipose tissue in terms of hyperplasia and hypertrophy terminology. Third one is it influences the energy metabolism. Here in the right side, energy metabolism, the right side to the ghrelin, if you see the pathways, almost all the pathways which are all ending with the hyperglycemia will be favored with the ghrelin action. Say for example, there will be decreased glycolysis, decreased TCA. Ultimately, it may favor hyperglycemia. And increased glycogenolysis, it is favoring the hyperglycemia. Increased gluconeogenesis, obviously it is favoring the hyperglycemia. And increased lipolysis, indirectly it is also favoring a hyperglycemia. So almost the ghrelin is influencing the energy metabolism to facilitate or to favor the hyperglycemia. That is the point to notify here with this slide. And last but not least, the ghrelin function, it influences the pancreas to favor increased insulin resistance. So it is not a function, it is a detrimental one. So I mean to say, the ghrelin is favoring the reduced insulin sensitivity. In other way, I can say it is reducing the insulin sensitivity. So coming to the role of ghrelin, leptin, and insulin resistance. So already I told you the ghrelin and the leptin are favoring opposite function. One is favoring the hunger, another one suppressing the hunger, and how it is connected with the insulin resistance, because our insulin resistance is the centerpiece for our obesity. So let us see here. Here the ghrelin, it increases the appetite. Up to 30% extra eating and the fat will be stored in the adipose tissue. And since there is extra eating and extra eating, so the hunger should be suppressed. So to facilitate that, the extra eating will give a signal to stimulate the leptin to secrete. So now the leptin will be secreted, but the leptin is inactive, not acting on the target organ, that is the organ is the adipose tissue. The reason behind is that the extra fat is not allowing the leptin to function. So thus it results in leptin resistance. And this leptin resistance, indirectly or directly, it is favoring the insulin resistance. So this is the idea behind this depiction of flow chart. So again, I'm repeating, the ghrelin with extra eating, So to suppress the extra eating, the leptin is supposed to secrete, and still after, in spite of the secretion of leptin, so we call it as hyperleptinemia, but there is no response at the adipose tissue. Ultimately, that results in the leptin resistance, and the leptin resistance finally becomes insulin resistant, make the insulin to resist, because there is no action with the leptin. All the time eating, because the leptin, if it is active, then the suppression of appetite, but there is no suppression because of the leptin inactive. So all the time the ghrelin is active, what will happen at one point, the patient will become, or the subject will become obese, the insulin is resistant. So coming to, before we see this adiponectin and other things, I wanted to, since the conference is, the symposium is highlighted with the thyroid, so though I am not so expert in the thyroid, but my level of approach with the thyroid and obesity is, there are two things I wanted to put forth before this August forum. That is, one is the effect of thyroid hormone on obesity. Just be thorough with this. Those researchers, really they want to pursue their research, they can use this tool. That is, there are two things I wanted to say. One is the effect of thyroid hormone on the obesity, and the other one is effect of obesity on the thyroid gland. So, seems to be similar, but quite different, quite contradictory with each other. So when we see the title, effect of thyroid hormone on the obesity, hypothyroidism stimulates the obesity. Hypothyroidism stimulates the obesity. So in the way, hypothyroidism, in the beginning, it decreases the thermogenesis, and then it decreases the basal metabolic rate, and the basal body mass index is increased, and obesity is triggered. And that is how we call it as hypothyroidism induced obesity. We call it as obesity is secondary to hypothyroidism. And the second one, the effect of obesity on the thyroid gland. So it is quite interesting. The obesity is stimulating the hyperthyroidism. It is not hypo, it is hyper. Increased T3, T4, and TSH also increased. So in the obesity induced hyperthyroidism, so this condition we call it as hyperthyroidism is secondary to obesity. Due to so many reasons, we can say either leptin resistance or increased pro-inflammatory cytokine, I mean the inflammatory markers increase. So many reasons are there. So you have to explore, as a researcher, you have to explore what is the real, because the research is still going on. They have not concluded. These are all the postulations. Some people even say there is very little connection between the thyroid hormone and obesity also. So you have to open your eyes. So coming to the adiponectin, in the obesity case, the adiponectin level is decreased. Because of the fall in the adiponectin, the increase of insulin resistance and the increase of reactive oxygen species, ultimately it can go up to atherosclerosis or the CVD disease. And the next one, about the resisting hormone, I wanted to say. So it is a recently discovered fat-specific hormone. It also increases the insulin resistance, and indirectly triggers the metabolic obesity. And last but not least, the pro-inflammatory cytokine, I mean the inflammatory markers, namely TNF-alpha, IL-6, the inflammation happens in the adipose tissue. So because of the increased ROS and oxidative stress, the obesity, atherosclerosis, and CVD will be caused to become in this condition. So To put it in nutshell, the obesity, adipose organ, adipose tissue, the TNF alpha release, the inflammation is caused. So it can result in the, because of the obesity, it may cause immune dysfunction, cancer, CVD, type 2 diabetes, insulin resistance. But I have to say insulin resistance is the centerpiece here, and even premature death may come. So I think I have finished my presentation in time. So let me have the Q&A after everybody's presentation, or it is up to the moderator. Thank you.
Thank you so much, sir, for a great presentation. If anyone has question, they can ask in chat box, or either in that person can mute yourself, unmute, and then can ask question from Dr. Mahadeva Rao.
Hello, Dr. Fahim, would you allow me if I can just ask something?
Yes, sir.
Prof Rao, I just want to have your comment on fat deposition and fat transport, because Gary, all these things is a very good presentation, and actually it brings us to the next level of thinking and approach. So, like, can we have a little bit, your point of view on fat transport and also deposition based in hypothyroidism or hypothyroidism secondary to obesity?
It's disturbing some noise. Yes. I don't hear.
Okay, Prof, can you hear me? Okay, Prof, I'm saying, like, with respect to what you have explained in a very nice way, and it is very informative for us. What do you think with regards to fat transportation and fat just what we call deposition with respect to Android and what we call the apple shape and pear shape obesity, what you have explained with respect to Ghrelin and this leptin sensitivity, and it's just very good for us. Even we have been working long time research, but it's a very good point of view the way you have explained it all. So, Prof, only from the transportation and the deposition point of view.
Okay. So, anything I want to explain?
No, Prof, I'm just saying, like, what is your point of view, like, associating this whole, what we call the thyroid, hyperthyroidism secondary to obesity, which was basically started, or hypothyroidism with respect to fat transport. And because what I think, like looking at the what we call the fatty liver and all those kind of things, it's getting very too much into this disease.
Okay.
Yes, Prof. Just want your comment on that.
No, regarding the thyroid,
Yes, Prof. Overall, yeah.
Overall, as I told, the center pin is obesity. As I told you in the beginning, if you take even fatty liver, that is the non-alcoholic fatty liver disease, then even heart, liver, bone, cancer, everything, even in the hyperandrogenemia, we call it as the PCOD, that is the Graafian follicle immaturation, unmatured. So the PCOD, everything is originated through the, so it is obesity is the primary cause for all the disease. But regarding the thyroid, but I am yet to confirm, because whatever the research from the reviews or the research I understood is still we have to go a long way. So that is why this platform will be very essential or very important to go further with our journey of thyroid hormone with the obesity. Because one side we see obesity is secondary to hypothyroidism. On the other side, we see hyperthyroidism is secondary to obesity. So though it is quite contradictory, we have to envisage much on this. We have to throw light on much on this thyroid area.
Okay, thank you, Prof. Thank you, thank you so much for a nice presentation, Prof.
Thank
It was
you.
very informative.
My pleasure. Thank you. Thank you.
Yes, thank you so much, sir, for a great presentation. From Bennett Methods, we're very grateful to you for your precious time and for your great presentation.
Thank you. My pleasure.
So I would like to invite our next speaker, Professor Dr. Thawin. She has joined us from University Sultan Zainul Abidin. So thank you so much, Dr. Thawin, for joining us. So I just hand over my mic to Dr. Thawin.
Mia, we have to unmute your mic.
Okay. Thank you, Prof. Thank you. Good afternoon, everyone. Firstly, I'd like to give my huge thanks to Prof. Dr. Adib, head of the Obesity Bank, UniSZA, professor from UniSZA, and Dr. Farim and Dr. Arhia from my Obesity and Black Obesity team and Brandy Health Education teams, and my fellow speakers and all the audiences. I'd like to share my knowledge briefly about thyroid hormones and its relation on obesity. I'll try to explain, for the sake of the time, I'll try to explain as short and as briefly as possible. Picture is the anatomical structure and position of the thyroid gland. It is placed in front of the neck. It's a butterfly shape below the cartilage of the larynx. Thyroid gland is one of the highest blood tissue of any organ of the body, and are made up of multiple acinar follicles and are lined by follicular cells and filled with colloid. So what are the hormones secreted from thyroid gland? As a basic knowledge, from follicular cells, thyroid hormones, namely tetraiodothyronine or tyrosine 4 and triiodothyronine or T3 are secreted. Between the follicles, there are parafollicular cells which secrete C cells, which lower the plasma calcium level. Calcitonin is secreted from parafollicular cells. This picture explains basic about the synthesis and storage of the thyroid hormones. From the plasma, there is iodide trapping actively transported into the thyroid follicle. Second step is oxidation, and third step is iodination. And then after that iodination, there is coupling, combination of monoiodotyrosine and diiodotyrosine converted to triiodothyronine T3, and combination of two diiodothyronine to convert the triiodothyronine is called T4, and these bound to thyroglobulin before they are secreted. Thank you. And when they are secreted, colloids are ingested by the thyroid cells, and thyroglobulin binding form is hydrolysis. And then free T4 and T3 are discharged into the plasma, in which there is the bind with the plasma carrier protein for thyroid hormone secretion. So for the transport of the thyroid hormone, as basic knowledge, total form of T4 is 8 microgram per deciliter and for T3 is 0.15 microgram per deciliter, and their binding form is more than 99%, as you see in the table. Free form, which is the more the active form, which has the effect on the target cells, it is 0.002 microgram per deciliter. Bound form is 0.003 microgram per deciliter. So I would like to explain a brief about the basic knowledge for the regulation of thyroid hormone secretion. From the hypothalamus, thyroid hormone is secreted to act on the anti-pituitary to stimulate the thyroid stimulating hormone, which act on the thyroid gland to secrete and give the T4 and T3 to give the metabolic effects. So when there is increase in the thyroid hormone free form in the plasma, they give the negative feedback action on anti-pituitary as well as on the hypothalamus. These are called, this is called hypothalamus thyroid axis. So when there is or foreign T4 and T3, TRH will be stimulated, and it is inhibited by stress, mainly mental stress, inhibit TRH. As well, when there is foreign T4 and T3 or TRH will stimulate TSH, and also there will be rise in T4 and T3 will inhibit, get the inhibition on TSH. Some of the inhibitory hormone, namely somatostatin, dopamine, which is the one of the catecholamines, glucocorticoids, which is the steroid hormone secreted from the adrenal cortex, they have the inhibitory action on thyroid stimulating hormone, and they can lower down the thyroid hormone level. So before moving on to the hyper and hypofunction of the thyroid hormone, I would like to discuss briefly about the basic action of the thyroid hormones. Even it is not essential for life because we can survive after removal of the thyroid gland. It is essential for growth and maturation, particularly the nervous system. And it has a calorigenic action, and it potentiates the catecholamine actions. These are also important. So in the deficiency state, we call, as Prof. Rao mentioned, hypothyroidism. Excess state, we call hyperthyroidism. And thyroid hormone acts as a metabolic regulator to maintain the homeostasis between these two extremes. So, as mentioned, thyroid hormones are essential for growth and development, mainly on brain and bone. During fetal and postnatal period, and it enhances the myelination of neurons and hence synapses. So it is essential for normal growth and skeletal maturation. Next is one peculiar action of the thyroid hormone is calorigenic action. So it has a heat producing effect. So as in hyperthyroid state and increase in calorigenesis, the effects would be rise in body temperature, increase in fat and protein breakdown. As well, vitamin deficiency would be precipitated and increase in secretion and motility of the GI tract. So hyperdefecation and can occur in hyperthyroid state. So as in hypothyroidism, decrease in calorigenesis, the effects would be decrease in body temperature, and there will be decrease in breakdown of sugars to whole. So that's why there will be weight gain. We can see in the obese person of hypothyroidism is due to consequences of this effect. And there will be decrease in mobilization of protein polysaccharide complex in the skin. So myxedema is the consequences of this effect is accumulation of protein polysaccharides and subsequent retention of the fluid. And due to the effect of the reduction and conversion of carotene to vitamin A, which consequences we can see? Yellowish discoloration of skin. So is it include sclera? No. In jaundice, we can see yellowish discoloration of skin as well as sclera. But in hypothyroid state, we cannot see include yellowish discoloration of sclera, only skin. And we can see constipation is the consequence of decrease in secretion and motility of GI tract. So also in our cardiovascular effect, due to the direct action on the acid node, it will increase heart rate and myocardial contractility, and this lead to increase in cardiac output. And cardiac output represent the systolic blood pressure, and to increase due to vasodilation, there will be decrease in total peripheral resistance and decrease in diastolic blood pressure. And combination of these two effects, there will be white pulse pressure. This effect is pronounced in the hypothyroid state. Again, on CNS, if there is hypothyroidism, there will be rapid celebration augmentation and reaction time of the reflexes will be shortened. Again, in skeletal muscle, it's essential for normal skeletal muscle function. In reproduction, it regulates the normal menstrual cycle, fertility, and lactation. So again, in metabolism, it acts on the carbohydrate and fat breakdown. Hyper, there will be increase. In hypo, there will be reduced. It stimulates the red blood cell formation to optimal level of red blood cell formation. And one important function is stimulate the synthesis of surfactant. For some other people in general population, I would like to explain briefly about the role of the surfactant. Surfactant is the lining of the alveolus, which is the functional unit of the lungs. So, in infants, newborn of the hypothyroid mother, they can be suffer from infant respiratory distress syndrome because they are deficient in surfactant and their lungs cannot expand well, and they will suffer from infant respiratory distress syndrome would be possible in the hypothyroid state. So let's move on to the obesity. So obesity is more than BMI more than 30. So what is the role of thyroid hormone in obesity? It's related to our symposium topic. So we should focus on the key role of thyroid hormones regarding the obesity, on basal metabolic rate, on thermogenesis, and regulation of body metabolism in starved and fed states. Hypothyroid disease is associated with marked changes in energy expenditure and body weight, and it will enhance protein breakdown, lipolysis, and typically weight loss. Hypothyroidism, these effects will be reversed in hypothyroidism. So before moving on to the hypothyroid, which is directly related to our topic of obesity, I'll go move briefly about the hypothyroidism. Clinical syndrome results from exposure of the body tissues to excess circulating level of free thyroid hormone, also called thyrotoxicosis. Causes are primary is at thyroid. Thyroid itself, secondary is at, according to the regulations, secondary is at pituitary, tertiary is at the hypothalamus level. Common cause is Graves' disease, which is the autoimmune disease producing thyroid-stimulating immunoglobulin or antibodies to thyroid receptors. So what are the typical features? You can see as the protrusion of the eyeballs accompanied by lid retraction, lid lag, and during sleep, there will be failure to close the eye. Also, it can lead to cornea dryness, ulceration, perforation, and also blindness. But the eye signs can be seen only in Graves' disease. This picture appeared obviously enlarged and protrusion of the eyeball. It is different from the individual with large eyes. In thyrotoxicosis, there will be obviously weight loss with partial and thyrotoxic myopathy. So let's we move on to the hypothyroidism. It is related with obesity. So we can call it is a metabolic obesity or it is the obesity or hypothyroid. It's a clinical syndrome results from inadequate exposure of the body tissues to free thyroid hormones. In adults, it's called basically myxedema. In newborn, it can call cretinism. So what are the causes? As in hypothyroid state, thyroid cause is primary, secondary is pituitary, and tertiary is hypothalamic cause. Common cause is iodine deficiency less than 50 microgram per deciliter. A research I found is in 2001. It is done in Malaysia. The data are from plankton. Within 1 year, post radioactive iodine therapy, there is incidence of 32.9% hypothyroidism. So we should be careful during the treatment of hypothyroidism by the drug treatment as well as radioactive iodine therapy. It can lead to hypothyroidism. Here we can see the children looks dropped and their height is lower than their actual average age, and they would be mentally retarded. And maternal iodine deficiency is the most common cause. And before the completion of the development of nervous system, to prevent the mental retardation, thyroid hormone replacement must be studied as soon as after birth. So the cretin, obviously, the newborn, where we can see the protrusion of the eyeball, protrusion of the tongue with the pot belly. Adult, and myxedema with the puffiness is the pitting edema, mainly around the eyelid and accompanied by enlargement of the thyroid gland. And, so based on the facts, consequences, based on this fact, there is reduction in basal metabolic rate to about 40% and completely dispassionate thyroid dysfunction in humans. What are the consequences? There will be weight gain. So in hypothyroidism, we can see weight gain or obesity, and the individual cannot resist go even with the bit low in the surrounding temperature. And to resist the cold, there will be vasoconstriction, and there will be skin will be cool, dry, and coarse skin, accompanied by coarse and sparse hair as well. So myxedema is a non-bitten edema in the eyelids, hands, and feet. It is different from heart failure. So consequences of carotenemia, there will be yellow skin, not in color. Constipation is the consequence of the decrease in secretion and motility of the GI tract. Peculiar feature of hypothyroidism is the husky and slow voice. It's the one disease that can be diagnosed over the phone, over the telephone. So the others would think that I might have hypothyroid because my voice is somewhat husky and slow, and not slow, but sometimes slow. But don't worry, it's solely on the genetics. My thyroid function tests are normal. And also in CNS, mentation will be slow and poor in memory, and mesodermal madness is the consequence, and there will be the hypofunction of the reflexes. In reverse to the action effect seen in the hypothyroid cardiovascular system, there will be decrease in heart rate, and it can lead to congestive heart failure. And the other changes in reproduction, there will be an increase in amount of the menstruation is called menorrhagia, infertility, and decrease in lactation due to reduction and fat breakdown. There will be a decrease linked to hypercholesterolemia and reduction in red cell formation due to the effect of anemia. We can see the pallor of the skin. And the one peculiar feature, there will be muscle weakness and myalgia. This is we can see both in the hyper and hypo state. And in goiter is the enlargement of the thyroid gland is endothelmic choroid goiter. So for the few seconds, I'd like to explain the mechanism how iodine deficiency causes goiter. A normal level of free T3 and T4 due to the negative feedback action on the anterior pituitary, no enlargement of the thyroid gland due to adequate iodine intake. If iodine inadequate, there will be low in T3 and T4, free T3 and T4, and there will be low negative feedback, and they act on the anterior pituitary to secrete a excess amount of thyroid stimulating hormone, which act on the thyroid gland to stimulate the cells to hypertrophy and also stimulate the growth of the thyroid gland and become enlargement called goiter. So this picture appears the obvious enlargement of the thyroid gland. The treatment is basically thyroid hormone replacement must be start soon after birth to prevent mental retardation. You need to do primary prevention by supplementation of iodine salt to mother. So I'll explain briefly about quadrogen. These are naturally occurring antithyroid agents, and when we consume tyrosine's in food, this can lead to hypothyroidism. So brassicas, the substances that can cause hypothyroidism, iodine deficiency are cabbage, rutabagas, tannate. So which contain proprietrin that is converted to active antithyroid agent quadrin. And if we consume a large amount of cabbage for a long time, we can get cabbage goiter. So these are some examples of the brassicaceae: cauliflower, rutabagas, cabbage, and tannate. So we can examine and we can test whether hypo or normal by thyroid function test, circulating thyroid hormone levels, measuring the total serum T3 and T4, radioactive amino acid measurement, and we can measure protein binding as well as hormone form. And also for discrimination, we can do uptake study. The tracer is orally administered. Thyroid uptake is determined by placing a gamma ray counter over the neck. And other thyroid investigation are thyroid autoantibodies measurements are recommended. Thyroid scanning is available. Radiology is also available. Thyroid biopsy can be done, and to test the histology, to study the histology. Also, we can also possible ultrasound scanning. Lastly, I would like to recommend some basic recommendation to healthy lifestyle. We should do exercise daily, even though, like the prof, just for joking, we cannot do hard exercise. We should walk around 5,000, 7,000, up to 10,000 steps per day. Another is we should eat healthy, balanced diet. This is the reference to the diet pyramid for Malaysian. 3 cruise food plan and energy building food like the breads and rice, 40 billion food like the protein and milk, and protective and regulative food like fruits and vegetables. And the top of the pyramid is less. We should eat less of the fats and oils, sugars, and salts. Water is definitely included in the balanced diet, because most of the people tend to forget about the water and the balanced diet. To the end of my presentation, but it is important recommendation. We should think positively. We should stay free from the stress, because stress stimulates and stress regulates many hormones, also the cardiovascular system, and stress stimulates the leptin hormone, which is directly related to the obesity, but it's not very directly related to our topic of thyroid, hypothyroid, and caring to the others more. These are the references. Thank you very much for attention. Okay, I'll end my presentation.
Thank you very much, Professor Dr. Tharwin. It was really a nice presentation. I have a question that can obesity lead to thyroid dysfunction?
Please repeat your question. Obesity?
Can obesity lead to thyroid dysfunction?
Obesity lead to thyroid dysfunction. For my knowledge, I haven't found the research about obesity. Is the obesity thyroid dysfunction? So cause is obesity, effect is thyroid dysfunction. In my knowledge, I'm not sure about that, but cause is thyroid, which is the state of hypothyroid. Hypothyroid is the effect, or effect is obesity. I just can clarify about that.
Thank you so much, Doctor. It was really a nice presentation.
Thank you. I'm sorry.
Okay. Our next speaker, Dr. Zareen Kiran, has joined us from Dow University of Health Sciences. She is assistant professor of endocrinology. So I will welcome Dr. Zareen Kiran.
Hello, good morning, and maybe good afternoon to some people around the world. I hope everyone can hear me.
Yes, you're clear now. Yes, we are listening you.
So can I share my slides now?
Yes, yes, you can share.
Can everyone see my slide?
No, I think the slide is not visible. Yes.
Can everyone see my slide now?
Yes.
Yes, it's visible now.
Okay. So thank you very much. I'm deeply honored to be invited in this international forum where I have been given a chance to talk on a very interesting topic related to my interest especially. So, and I thank Professor Rao and Professor Madhya about, going through the basics and the background. My topic would be easier, I hope. So it is about weight management in obese with thyroid malfunctioning. Um, how would I move the slides? I am not able. Okay. So I will be covering about. I will tell you about what I've gone through the literature related to thyroid and body weight. And I just picked up a question which was addressed to Professor Madhya about obesity leading to thyroid dysfunction. Maybe the research points which I'm going to tell may answer that as well. So physiological relation between thyroid hormone and body weight has quite been explained previously by the eminent speakers, and then thyroid dysfunction and obesity. I'll give a background of how this happens, what are the nitty-gritties in that, and then the management, of course. So we all know obesity is a rising pandemic all over the world now, and it has nearly tripled. And this is the report of WHO as of 2016, where they say that 39% of adults aged 13 years and above are overweight, and at least 13% were obese. But I'm sure over the last four years, now the percentages might have rocketed further. Sadly, children are also, even under the age of 5, they are obese, and childhood obesity is now becoming a separate problem for all healthcare providers. So causes of obesity are diverse and reverse from several endocrine disruptions in the body homeostasis, we all know. And one of the most frequently encountered endocrine abnormality in obese patients is the altered thyroid function, as hypothyroidism is quite well associated. Little bit about the brief definition of WHO regarding obesity, overweight, and obesity. They are defined as abnormal or excessive fat accumulation that presents a risk to health. And a crude population measure, the way how we measure obesity is obviously the body mass index, the BMI. And this is done by, getting a person's weight in kilograms divided by the square of his or height in meters. And we define it when the BMI of 30 or more is generally considered obese, and equal to or more than 25 is considered overweight. So these are the WHO recommended definitions, but the Asians, the Japanese, and the Europeans, Caucasians cutoffs, they do differ, and one has to look into their own ethnicity and population statistics. But these are the reference points. Now, as I was going through this topic, so I wanted to know what is the real data we have regarding obesity and thyroid. So one leading to the other, I heard Dr. Rao, Professor Rao mentioning about it, and very interesting research topic actually. And I believe we don't have a large epidemiological data on that. So I got these points from decade ago researchers. And it said that autoimmune thyroid dysfunction has been reported in 12.4% in obese children and between 10 to 60%. I mean, this is a big reference range. 10 to 60 is a quite big. So obviously data is differing, and we need robust kind of epidemiological studies to collect the correct data. On the other hand, 8% of morbidly obese patients were found to have raised TSH, means they were not really they do not have the thyroid dysfunction in the background, but when they were tested for the TSH level, so this was the value they got, that it was between 4.1 to 19.9. Again, the reference ranges do differ from different population depending upon the iodine content they take and age, gender, and everything. The prevalence of overt and subclinical hypothyroidism was 19.5 in one of the study where they studied morbidly obese individuals, and these were taken as having no prior thyroid disorders. So this is what is the real story is. And so the morbidly obese subjects have higher levels of total T3, pre-T3, total T4, and TSH. Um, so I think I don't need to explain the slide. So clearly it is so much self-explanatory that obesity is leading to so many medical complications. And since I've been in touch with several other, endocrine and obesity related forums. So in one of them, I also heard, in fact, I had seen a slide where obesity was leading to more than 250 health related complications. So here what you are seeing is just a surface view of main medical problems that we encounter in our daily life. So health consequences of being obese or obesity, it basically lead to serious medical complications that impair the quality of life, increase the morbidity, and premature death. And obviously, it is associated with so many endocrine abnormalities, first and foremost being thyroid dysfunction. Dr. Madhya has quite well explained the thyroid hormone physiology. This is just an overview of what main target metabolic areas where thyroid really function, especially the mitochondria, the glucose transport, and the basal metabolic rate. So the thyroid hormone is actually acting on all nucleated cells of the body. A very beautiful graph in one of the famous book of Guyton and Hall of Medical Physiology, where the relation between the basal metabolic rate and thyroid hormone has been displayed. So increased metabolic activities of all tissues of the body, that's what the main function of thyroid hormone is. And you can see from the graph that even a minor slight change in the thyroid hormone level leads to quite significant change in the basal metabolic rate. So it can increase up to 60 to 100% when large quantities of thyroid hormone are released. And on the other hand, when no thyroid hormone is produced, then the basal metabolic rate falls to almost 1/2 normal. A very beautiful graph one students should remember. So being an endocrinologist, you're always, running after hormonal profiles and then the metabolic parameters, and especially the anthropometric related to obesity. You want to know the BMI. So a Danish study of 4,082 patients was reported in 2005, where they found that as there was a slight increase in the TSH level, there was a concomitant increase in the BMI, even though they do not have any thyroid dysfunction. So this is an observation. This is what probably was questioned in the previous session, that is obesity leading to thyroid dysfunction? We don't know. This is still an observation, and it is dating back to like more than a decade ago, and still data is coming up and research is going on. But you can clearly see how even minor changes in TSH is leading to, changes in the BMI. And of course, the role of other hormones have also been explained. I found leptin to be quite closely related with thyroid here. So obviously, leptin produced by adipocytes does regulate energy homeostasis by informing the CNS about adipose tissue reserve. And it modulates the behavior response to feeding, the food intake, energy expenditure. But it is also a neuroendocrine regulator of the whole hypothalamic, pituitary, and thyroid axis. How does it do that? It regulates TRH gene expression, the thyrotropin releasing hormone released from the paraventricular nucleus of the hypothalamus. And then in turn, the TSH then stimulate leptin secretion by the human adipose tissue. And leptin also affects the thyroid deiodinase activities within the peripheral tissues with activation of T4 to T3. So you see, leptin is so closely linked with the thyroid axis. And this is something where interventions for obesity may help in future. We all are quite aware and have already gone through the symptomatology and clinical presentation of hypothyroidism. Professors have explained very well. So obviously hypothyroidism leading to poor appetite, carpal tunnel syndrome, puffy face, mixed edema features, weight gain. These are all very much clinical interest to clinicians to look at. And an exhausting list of the causes of hypothyroidism should not be ignored. The reason being that the patient always asks that, why me, doctor? Why this happened to me? So you should have an answer. And sometimes some treatments are required which are a bit different from the other to address thyroid issues. So even though the mainstay of treatment of hypothyroidism remains thyroid replacement, but you may have some drug-induced causes to address, and then sometimes the thyroid disorder may be associated with other problems like hemochromatosis and so on. So I mean, list should be there in your mind that we have to look at. So an example of this of a cause of hypothyroidism is a defect in the conversion of T4 to T3, and this is quite molecular and of biochemical interest actually, where the deiodination does not take place at the target cell, and the T3 hormone, which is the active hormone at the tissue level, is not there, and when it's not there, the basal metabolic rate would go down and energy expenditure would decrease, and this would lead to weight gain. Okay, now the association of thyroid dysfunction with obesity. There are certain points in the literature and certain questions. I would say these are the real research questions one can again dig in their own individual population, whether this is right for them or not. Obese patients, they have increased TSH, increased peripheral hormones without any thyroid disease. This was very well, discussed about in earlier. And then thyroid dysfunction is associated with changes in body weight and composition, and this is independent of physical activity. If there is a dysfunction, then the changes in body weight will take place regardless the patient has been following a very healthy lifestyle. And then weight gain often develops after treatment of thyroid dysfunction in hyperthyroidism. So this was also talked earlier about that when you treat hyperthyroidism, obviously you are addressing the basal metabolic rate problem, and then obviously weight changes are expected. And both subclinical and overt hyperthyroidism are frequently associated with gain, decreased thermogenesis, and metabolic rate. So how is this really happening? Why the obesity is arising in altered thyroid function? There are various mechanisms, and still I'm sure mechanisms are being studied and researched. So, and the main aim behind the altered mechanisms is to increase energy expenditure in an attempt to further reduce the weight gain, which is happening. Most frequent mechanism which I went through was the influence of leptin that I've already talked about, and thyroid hormone resistance, which I'm going to go through quickly in next few slides, and a very broad, topic, which is mitochondrial dysfunction. So, I mean, these are the points which I've gone through, which I came across, but I'm sure there may be other which is going on. So, a moderate increase in total T3 or free T3 levels has been reported in obese subjects. And progressive fat accumulation is associated with increase in TSH and free T3 levels. This is irrespective of insulin sensitivity or other metabolic parameters. So fat, that means adipocytes, if they are increased, if they are becoming hypertrophic or hyperplastic, then TSH, T3, they will rise. And this is independent of other metabolic. And then positive association between free T3 to free T4 ratio, and both the waist circumference BMI and these patients have been reported as well. Now you may be thinking these are quite interesting research topics actually, and these variables have been studied in different studies where they try to make a link and understand how thyroid dysfunction is leading to obesity or leading to abnormal weight in these patients. So usually we are supposed to have a high free T4 to free T3 ratio in the normal subjects. But in case of obese patients, the free T3 is on the rise as compared to free T4. And this altered ratio is very well associated with waist circumference and BMI. So weight loss induces a reduction in both TSH and free T3. This results in increasing the reverse T3 levels due to reduced 5-deiodination. Because this 5-deiodination is supposed to increase in excessive fat. When the fat content is increased, the enzymes are also increasing. And when they are increasing, they are converting more T4 to T3. And this T3 is trying to, make a compensation and by increasing the energy expenditure and maintaining the weight. But when patient loses the weight, loss of adipocyte and mature cells, the reverse is happening, and TSH and free T3 are going down, and in fact, reverse T3 is on the rise. So this is what, following weight loss, T3 concentrations decline. This leads to decrease in resting energy expenditure and then total energy expenditure as well. Therefore, we can say that decreased T3 levels may be responsible for difficulties in maintaining or further decreasing the weight loss. So the cycle is so closely, the mechanism is so closely interlinked that slightest decrease or change in hormone level is affecting the weight. Then there are factors like TSH receptors. They have also been studied, and they are less expressed on adipocytes of obese versus lean individuals. Now, when there are no TSH receptors, they are reducedly expressed, then this would lead to downregulation of even thyroid hormone receptors on those fat cells, further increasing the plasma TSH and free T3 concentration. This is the phenomena known as peripheral thyroid hormone resistance. This is a bit different from the one we study as a central or peripheral thyroid hormone resistance, which is genetically associated, but because this is reversible by weight loss, restoring the size and function of mature adipocytes. And when the number of adipocytes are decreased, TSH receptors would comparatively become more prominent and increase, and then upregulation of thyroid hormone receptor will take place, and then TSH and free T3 will normalize. A bit about the role of ultrasound in such cases, and it just says that thyroid structure evaluation by ultrasound is not any helpful to determine whether patient have a thyroid problem or hypothyroidism in obese patients. Because an increase in thyroid volume has been observed along with hypoechogenicity, which suggests ultrasound pattern of just like Hashimoto's, although there is no thyroid antibody there. Why does this happen? Because in obese subjects, we all know adipocytes are making more cytokines and inflammatory markers. These are leading to vasodilatation and increased permeability through thyroid vessels, and thus the thyroid size is increased. This is the ultrasound feature of a thyroid gland where the blood flow is increased, and it's just like a picture of Hashimoto's thyroiditis. Now, let's talk now about weight management. Again, we have to be very practical with weight management generally. But when we find a hormonal cause, we become very happy. We being clinicians have a reason to tell the patient, okay, you have this thyroid problem, now you will be able to lose weight. But be cautious, be very practical and knowledgeable that how much weight reduction you can achieve. So the goal of treatment in patients with primary hypothyroidism is to return the TSH to normal. You should not overtreat. And early clinical response is quite clear with a diuresis of 2 to 4 kg. Why do I say diuresis? Is the reason that when in hypothyroidism, the glycosaminoglycans in the subcutaneous tissue and loose connective tissue all over the body are retaining more water. So as the hypothyroidism is being treated, a diuresis form of phenomena takes place, and patients lose some weight. And this expected weight loss, once the treatment begins, is actually small, often less than 10%. So patients should not have very high expectation if they are generally obese due to other reasons. So treatment should result in a return of body weight to before developing hypothyroidism. So these are all, history and physical examination points which a clinician should ask. That's the reason, patient comes up and says, doctor, it's weight and only weight. So it is very common to find there is no significant weight loss even after successful treatment of hypothyroidism. If all other symptoms are resolved, then weight gain is less likely due to thyroid alone. And then you have to counsel the patient and tell the patient, okay, thyroid has been treated. Now please look into the other causes of weight gain. look at your diet, look at your lifestyle. Once thyroid hormone levels have returned to normal, the weight dynamics are just like individuals who do not have thyroid problems. Again, in treating hypothyroidism from several point of view, the non-specific symptoms of true hypothyroidism can also be there, which can misguide, like fatigue, anemia, menstrual irregularities, and the weight gain. So patient can come that, okay, I have developed weight gain of so and so kg for the last so and so months. I did my thyroid test and TSH is coming a bit on the higher side of the range. From say, for example, if the range is 0.4 to 4.9 and the range and the test comes out to be 4.5. Okay, doctor, I have these symptoms. My weight is on the higher side now. Now please treat me. No, thyroid hormone therapy should be avoided in patients with no biochemical evidence of impaired thyroid function. Be worried about it. And in this regard, I went through the literature. What I observed was the data which was there in overweight and obese children. And they were hypothyroid. When they were hypothyroid and they were treated for TSH, there was no significant effect on the change in their weight. And this was surprising. And efforts to reduce the slightly high TSH in such patients, in such group of children, actually lead to iatrogenic, subclinical, or even overt hyperthyroidism. So be careful with the biochemical value and see what other factors are. This is the area, this is the point, or this is the research aspect where children with obesity need to be addressed. Obese children with isolated high TSH levels confirm that there is no need for thyroxine treatment. Once they start losing weight, majority of children can have normal TSH levels in the follow-up, regardless whether they took the thyroxine or not. This was studied. There is a data on that. So accordingly, the guidelines from Thyroid Association in the Europe, for the management of even subclinical hypothyroidism says that in obese patients with TSH levels between 5 and 7, they are the result of excess body weight. So ask them to lose weight through lifestyle intervention and then review the TSH. You'll get a normal TSH. So the question is, does weight loss have an influence on thyroid function? Weight loss can be achieved by lifestyle interventions, pharmacological treatment, bariatric procedures, and a combination of them all. And a study has shown that the lifestyle intervention to reduce the weight can decrease the fat mass, which in turn is associated with decrease in TSH levels. And this decrease in fat mass and its association with TSH I've explained earlier. So again, the question comes that should we treat thyroid dysfunction in obesity? This was first attempted in somewhere in 1940s and 50s to induce weight loss in obese patients with thyroxine, although they did not have any thyroid problems. And this was based on the observation that patients who were hyperthyroid had decreased their body weight by 15% in the course of their illness. And this was like a blessing in disguise. But this for this disguise to work, you need a disguise, right? So in supraphysiological doses, thyroxine therapy resulted in muscle wasting, weakness, adverse cardio effects, which leads to subclinical or even overt hyperthyroidism, and then you stuck up with those problems. So you have to be careful in these mistakes, clinical mistakes. So is there still some room there? Can you still have some indication to treat patients with weight problems, having minor thyroid problems? So indications have been there for subclinical hypothyroidism who have hyperlipidemia, and addition of total T3 in case of patients who had adequately substituted hypothyroidism with obesity resistant to lifestyle intervention or suspected of having thyroid conversion disorders, which are psychiatric problems. So available data in such case says that it is insufficient to assess how thyroid hormone will influence the fat and muscle loss in obese subjects during this caloric deprivation and consider the risk of hyperthyroidism. Such therapy should be avoided in thyroid patients. So although these things are in practice, these treatments are in practice, but the data to support and recommend is still lacking. So in summary, I would say that the weight dynamics are an integral part of thyroid dysfunction. Crucial metabolic derangements are closely interlinked between main endocrine organs like adipocytes and thyrotrophs, and large epidemiological studies are lacking, requiring research-intensive results. Lifestyle intervention remains an essential component in all weight management strategies. Thank you so much for your kind listening. I will take the questions as desired.
Thank you so much, Dr. Zarintian. It was really a great presentation and great learning opportunity for all of us, for all participants. New things, we have learned a lot of new things in your presentation. So I would love to, in our next sessions, as a guest speaker, as we learned a lot from your presentation.
Thank you very much.
So our next speaker, Dr. Ayesha Iftkhar, she is CEO Naurish by Ayesha. She joined us from Pakistan. So I would like to welcome Dr. Ayesha Iftkhar. Dr. Ayesha Iftkhar, are you listening?
इस टाइम में सुस्ती होना शुरू होती है तो मुझे समझ आई है जब मैं उठती 12 बजे हो ना तो मुझे उठते साथ ही सुस्ती हो रही होती है ये ना कोई 12 से लेके 4 बजे तक सुस्ती का टाइम होता है तो सुबह
Dr. Ayesha Iftkhar.
Yes.
Yes. How you can share your presentation now? Yes.
I cannot hear you properly.
Dr. Ayesha Iftkhar, are you listening me now?
Yes, I can hear you.
Yes.
Okay. I'll be presenting on the calories and weight management for hypothyroidism patients, particularly. Before starting that,
Dr. Ayesha Iftkhar, sorry to interrupt you.
Yes.
Would you please set your mic, set your camera, as it's, I think it's not proper arranged.
Okay, what it is arranged my camera. Let me just figure it out. Okay, can you see me now?
Yes, it's okay.
It's okay now?
It's
okay.
excellent.
Okay. Good. First of all, I want to thank each and every one of you to be over here, and I want to thank the organizing committee to invite that has invited me over this international symposium. So the topic of my presentation is basically about the calorie and weight management for hypothyroidism patients. I won't be going into the causes of hypothyroidism and all the things that that is actually discussed previously. So I'm a clinical dietitian, I'm a consultant dietitian, I'll be focusing majorly on the diet. So what are the do's and don'ts of the diet, and which foods can interact with the medication of hypothyroidism? So we'll be discussing on these terms. Before starting the presentation, I need to tell you one thing, that I myself is a hypothyroidism patient, so I can relate to this topic really well. So all the weight gain, how to lose weight, what are the calories, each and everything. I know, I have personally experienced all these things. So let's start the presentation. The way I present the topic is quite casual. So I want to relate to the audience that is basically listening. So I'll just be speaking and making you understand all the basics and all the advanced levels of the diet of hypothyroidism. So let's start. The first thing is the medication interaction and the food. Which foods can interact with the medication of hypothyroidism? So that is very much important. The first thing is that soybean flour or walnuts can interact with the hypothyroidism medicines. So it should be taken at least 2 or 3 hours after you have taken the medicine. Dietary fiber can decrease the absorption of the medication that you're taking. We have iron and calcium tablets, antacids that needs to be taken at least 3 or 4 hours after or before that you're taking the medicine. So all these points, all these things are really important. If you are taking the medicine and if you're taking all these foods that I've listed down, so the benefit, you won't be getting any benefit out of the medicine because it will not be absorbed in your body. So the second point is very much important, and I think most of you will be are waiting for the point, that is possible nutrition concerns. What are the possible nutrition concerns of a hypothyroidism patient? So the first thing is, as it is explained earlier, that in hypothyroidism, your metabolism is decreased. Your metabolism rate is basically decreased. So the carbohydrate metabolism is decreased. If a person is diabetic, automatically it has a certain consequences to it. The ability of the body to break down the hormone insulin is decreased. The transit time of the gastrointestinal tract is decreased, so a person can feel constipated. All these issues can happen as the metabolism rate is decreased, so a person can suffer from high LDLs and low HDL level, high cholesterol levels. So these are certain issues that can actually occur. For example, that is why if a person is constipated, the first reason if a person is constipated, and I've told you earlier that dietary fiber interferes with the absorption of medication. So it is suggested that if you want to take high fiber food or simple fiber, soluble or insoluble fiber, you should be taking it at least 2 or 3 hours after you have taken the medicine. Okay. First, we need to be on the point that hypothyroidism basically, if a person is suffering from hypothyroidism, the patient will be having at least 10 to 12 pounds of gained weight. So that is the first thing. The second thing is that is very much important is it can be due to excess weight water. It can be due to any other reasons, but the basic is that at least if a person is hypothyroidism and if he or she loses weight, so the American Thyroid Association says that almost at least minimum amount 10% of the body weight that the person has, it's because of hypothyroidism. So we can eventually if it is treated well, we can lose at least 10% of the body weight that has gained. First, then let's discuss about certain things that we need to consider. First is basically about the iodine. Iodine is an essential nutrient that needs to make the thyroid hormone. So if a person has an iodine deficiency, that the person is at a risk of hypothyroidism. For example, the foods that are that interfere with the iodine absorption, we always say that you restrict or modify that intake. For example, cruciferous vegetables, they are rich in sulfur, they are rich in they actually in the person who has a goiter, we actually avoid all these things. So a person with for example, if a person has hypothyroidism, we say that you need to take iodine-rich foods, for example, seafood and fish, anything that has iodine in it. The second thing is eggs are really good. We actually recommend eggs, or we recommend dairy, fish, to all those people who are suffering from who are suffering from hypothyroidism. We don't recommend iodine supplements. So iodine supplements are not necessary. If you are taking enough iodine in your diet, that can help you in treating hypothyroidism. The second nutrient that is very much important is selenium. Selenium helps to active thyroid hormones so that they can be used by the body. So selenium has other benefits also. It has antioxidant properties also. So what you can do is you can add selenium-rich foods. For example, nuts, we have eggs, we have legumes, they are selenium-rich. So you can add all these nutrients to your body, to the daily diet, so that you can treat hypothyroidism well. The next nutrient that we'll be discussing is about zinc. Zinc is extremely important. As selenium, zinc also helps activate thyroid hormone. Studies show that zinc helps the body regulate TSH, the hormone that tells thyroid gland to release thyroid hormone. So zinc deficiencies are extremely rare in developed countries, but they are very much in the developing countries, and we are in the developing country. So we need to take an abundant amount of zinc in our diet. If zinc-rich foods are beef, chicken, fish, seafood, they are rich in zinc. So we need to take all these food in our diet. Before telling you the do's and don'ts of the diet, I need to first say that diet is really important. That can help you or aid you in treating or preventing you from hypothyroidism, but it is not the only thing that you have to focus. It is a triad basically. You need to exercise, you need to take medications at the proper time, and you need to focus on the food that you're eating. So it is actually a triad. It is basically a holistic approach. It is never one thing. If I'm telling you that selenium is important, zinc is important, or that iodine is very important, it can aid you, it can support you, but it cannot treat you fully. So you need to take medications at first. So if you want to treat your hypothyroidism, the first thing is that you need to take medicines timely, properly. That was previously explained. I think that was previously explained. The very important thing is NHS. Everyone knows NHS. NHS stated clearly that no single food can treat hypothyroidism. There is no food in your diet that can help you basically to say that okay, if you take this food, you can prevent or you can treat hypothyroidism. It is always a holistic approach. It is always a holistic approach. It is always a balanced diet that can help you. So as I myself is a hypothyroidism patient. I gained a lot of weight. I gained around 20 kgs because I was undiagnosed. Once I was diagnosed, then I tried to lose weight. So losing weight is actually really difficult for hypothyroidism patients. They don't know what to add in your diet, what not to add in your diet. So let's just discuss the NHS guidelines about hypothyroidism patients. First, you need to have a lot of patience. Because as I told you earlier, that hypothyroidism patient the weight gain is not that much easy for a hypothyroidism patient because the weight plateau occurs quite often. So you need to have a lot of patience, first of all. Second, you need to take at least 5 portions of fruits and vegetables. We focus on raw fruits and raw vegetables rather than fruit juices because as told earlier that hypothyroidism patients can get constipation. Can suffer from constipation. So fiber is very much important, and you can add fiber in your regular diet through fruits and vegetables. So at least 5 portions of fruits and vegetables are very much important. You can increase the intake according to your need, but it is the minimum amount. So add at least two fruits and 3 or 4 vegetables in your diet per day. The other thing is, as told earlier, high fiber diet is the key. So you need to take extra fiber in your diet. For example, you can have husk, you can go for whole wheat cereals, you can have seeds that can add fiber to your diet. All these things you can have whole wheat pastas, you can have whole wheat bread. So all these things can add fiber to the diet. The next point is that you need to have dairy products in your diet. You can go for low-fat milk or 2% fat, 2% milk. You can have. I do not prefer going for a processed food. Rather than I prefer we do that in home. For example, we can eliminate fat. We can extract the fat at home. You can boil the milk twice, and you can remove the fat. So that is actually a low-fat milk for you. So you can take milk, you can take yogurt. Yogurt is a very good probiotic. So as told earlier that GI tract is basically suffering. So you can add probiotics in your diet. That is very much important. For selenium and zinc, if you want to add selenium and zinc in your diet, do add beans and legumes. So legumes are rich in protein, they are rich in zinc, they are rich in selenium. So you can add protein to your diet, eggs, fish, lentils. Do add all these things because protein actually help you to lose a bit of weight. So that is actually true. So do add all these things. The very much important thing is, as told earlier, the person can suffer from high LDLs and low HDL levels and high cholesterol levels. So a person has to take heart healthy foods. What are heart healthy foods? And you need to reduce saturated fat intake to at least 7%. That you need to limit. You don't have to take sugar, simple sugars. You have to restrict simple sugars. It is the guidelines that says at least 100 kilocalorie from simple sugar should be taken. For the maximum intake is 100 kilocalories for women and 160 kilocalories for men. So you don't have to take extra amount of sugar, simple sugars, or foods that have sugars, simple sugars in it. What else? You need to take unsaturated fat in your diet. Omega-3, omega-6 is heart healthy fat. So do take all these fats in your diet. Heart healthy diet has ample amount of fiber in it. So as told earlier, you have to take ample amount of fiber in your diet. That is very much important. Drink plenty of water. If you want to lose weight, if you want to treat hypothyroidism, your body should be well hydrated. That is the key. And how to take water. The second point actually say that you have to drink plenty of water. How to take it? You have to take you take sips of water divided in the whole day rather than gulping a whole glass of water in your body. So if you drink small frequent, if you go for sipping of water the whole day, you will actually the water will actually help in the digestion. If you take excess of water at one time, it will flush off from the body. So basically it will be of no use. So take sipping of water. That is very much important. The next point that is extremely important is you have to take nutritious food. Avoid junk, avoid simple sugars, avoid carbonated beverages because they are rich in sugars. At least a half liter of bottle has a lot of sugar in it. So you need to restrict on simple sugars. You need to restrict on processed food. Take homemade food, nutritious food. That is the key to hypothyroidism patient. Yes, you need to cut down on bad carbohydrates and you need to add good carbohydrates, the complex carbohydrates in your diet. It will take time. What you will be doing is you need to restrict certain calories because a person is actually overweight. So you will be restricting 600 or 700 or 500 kilocalories depending on the individual routine and lifestyle. So you will be restricting at least 500 to 700 kilocalories per day. With that, you will be adding carbohydrates, complex carbohydrates. You will be adding lean protein. Lean protein is the key. So you won't be adding dark meat, red meat. You will be adding eggs, egg whites, the whole egg, fish, chicken. You will be adding all these things, lentils in the diet rather than you won't be preferring red meat. As told earlier, that cholesterol levels can be high in the hypothyroidism patients. So what else is left? Exercise. Exercise is extremely important for the hypothyroidism patient because metabolism is decreased. So to increase the metabolism, to get the kick, you have to exercise. For hypothyroidism patient, we prefer moderate to intensity exercise. The high intensity exercise, we prefer that. So moderate to high intensity exercise, we do prefer. So it is a mixture of cardio and resistance training. It is preferred to have both the combinations, like resistance training that has a bit of weight in it and cardio. Do not go for only cardio or do not go for only resistance training. It is always a combination that can give you the best results. So at least the research says that for weight loss, you need to, if you want to lose weight, if you need to get rid of the extra pounds that you have gained, you have to exercise at least 60 to 80 minutes per day. for a shorter period of time, basically. So you need to exercise at least an hour to get rid of the extra calories that you have gained. Because hypothyroidism patient, you have to have a lot of patience. So you will be exercising at least 50 or 60 minutes per day, but the results will be not that, will be less than the expected ones. So you have to have patience. That is very much important. The last point that I'll be explaining is the mental health. Because I am hypothyroidism patient, I know there's a lot of stress, there's a lot of mind game going on. So you have to have a bit of patience with that. You need to be very positive about your life. So if you have, because if you have hypothyroidism, you have to be on medicines. You have to see your diet. That is very much important. And the other point is that you will not be comparing your weight progress with the other person, because the other person is not suffering from any disease. So all the things will be a bit different. So mental health, low stress, exercise, healthy eating, a balanced diet is very much important. The results will show. At least you are moving ahead. If you're losing 1 kg or 2 kg, you are losing something. So something is better than nothing, rather than you want that you have to lose at least 5 kgs in a month. It can be possible to certain persons, but in my case it was not. So I lost at least 6 kgs in 2 months, and it was really hard for me to lose weight, that much of weight. So I know what it feels like. I know a lot of patients. I know a lot of my clients actually say that they are not losing weight, they are at weight tattoo. But our goal is to eat healthy, and the results will be shown later in the life. So that is basically the end of my presentation. That you need to eat healthy, you need to eat nutritious food, you need to cut back on bad things that you are eating. It is never one day. The diet is never a pill. It is not a magical pill that you will be eating it and you will be getting results out of it. So you need to be consistent. Consistency is the key. Moderation is the key, and patience is the key for hypothyroidism patient to lose weight and to restrict their calories. So thank you so much. I hope you enjoyed my presentation. It was quite a presentation that was, I made it quite, I delivered in a very simple way so that everyone can understand what I'm saying and they can easily relate to what I'm saying. So I hope each and everything was clear. So if you do not have any, if you want to ask questions, you can ask me. And thank you so much. And that's it.
Thank you, Dr. Ayesha. It was really a very informative session with
Yeah.
you. I have a question that how much insulin should be recommended in hypothyroidism patient, and can it be fulfilled only through diet?
I cannot hear you. Can you repeat the question again?
Question is that how should be recommended in hypothyroidism patient?
How what?
Selenium, how much selenium should be recommended in a hypothyroidism patient, and can it be fulfilled through diet?
Okay, yes, selenium can be fulfilled through diet. Basically, the other thing is the recommended amount is basically individual to individual. So it is never that this much amount of selenium is recommended, and if you add selenium, this much amount of selenium is added to the diet, it will prevent or it will treat hypothyroidism. So I said it earlier that these nutrients can only aid in treating hypothyroidism, but the key is moderation and the key is balanced diet. So it is never the amount of selenium. It should be like you have to eat selenium in your diet. It is never that you should only be eating selenium and that much amount of selenium is added to your diet. So the amount is basically individual to individual. It is totally, it depends on, yes, it depends totally on patient to patient, that what the patient is, how much critical is he or she. So all these things, all these factors are important to calculate the amount of selenium. So it's never one figure, basically.
Okay. Okay, thank you so much, Miss. Thank you very much.
Welcome.
Assalamu alaikum. Fahim, can I ask one question if you allow me?
Yes, yes, sir. Please ask
Thank you,
question.
Dr. Ayesha, for a very nice presentation. I'm sorry, actually, the messages go wrongly to you. So, I just want to ask you regarding, in case of like what Dr. Zareen just mentioned a few minutes back, with the Hashimoto versus non-Hashimoto kind of disease. But the issue in both of them, we do get the fatty liver, in majority of the obese subjects. So,
Mm-hmm.
with respect to obese and overweight, Hashimoto versus non-Hashimoto, do you think? But my question is basically using of ketogenic versus non-ketogenic diet in
Hmm.
thyroid. So this is one of the very
Hmm.
burning topic, which actually a lot of people who are basically who are dealing with hypothyroidism, they have into using a ketogenic diet, where
Hmm.
they actually don't lower down basically the amount of lipids or fats. So I think
Hmm.
you already understand my question, what I'm trying to ask. So we need your comment on that in a very simple way, like which is easy for a layman also.
Hmm. Okay. As told earlier, ketogenic diet. Okay. Let's just see what ketogenic diet is basically. Okay. Ketogenic diet was the purpose of ketogenic diet was to treat epileptic patients. So it was for epilepsy. First thing is that for keto, as told earlier, I have told all the NHS guidelines. I have told the Harvard guidelines. The key is the balanced diet. It is neither. It can never be Atkins diet, ketogenic diet, banana diet, any form of diet, because it is not hypothyroidism patient. Hypothyroidism is not an acute disease. Like, I am on medicine for quite a long time, so you have to opt that type of diet that you can stick to it. You cannot stick to ketogenic diet for a longer period of time. First thing, as told earlier, okay, there's another point. As I'm a consultant dietitian, I work in the hospital. So a lot of people actually are not using ketogenic diet, but they are using Atkins diet and they are terming it ketogenic diet. First thing, ketogenic diet is high fat diet. You have to take a lot amount of high fat, and you have to restrict carbohydrates. You have to limit your protein. Atkins diet is basically a high protein diet with a moderate amount of fat and a moderate amount of carbohydrate, that is complex carbohydrate. A lot of people are using Atkins diet and referring it to ketogenic diet first. As told earlier that the GI tract, the GI tract is basically is suffering right now. The transit time is basically delayed. You have LDL, high LDLs and low HDL levels. You have high cholesterol levels. So as a dietitian, I do not go for ketogenic diet for hypothyroidism patient. I myself did not practice it on me. So I did calorie deficit diets, that was to restrict my calories. Second, I only opted high fiber and those things, high fruits and vegetables intake, high fiber diet, and I lost 6.5 kgs in 2 months, and that is a big thing for me. Like, if someone deals with hypothyroidism patient, that person knows that it is very difficult for you to lose weight, and I have lost that much amount of weight. So I have treated a lot of patients with balanced diet. I don't support basically ketogenic diet that much for hypothyroidism patient or for any other disease. Yes, certain cases are there. If a person has epilepsy, if a person has any neurological issues, we can recommend ketogenic diet, because the purpose of ketogenic diet was to treat all those things. So I don't go for ketogenic diet for hypothyroidism patient. If you will eat balanced diet, it will take time, but you will not feel depressed, because mental state is very much important in hypothyroidism patients. So if you're restricting everything to you will be eventually be depressed in the longer run, because you are unable to eat it. So key is the key is calorie deficit, and to restrict your calories, go for high fiber, go for fruits and vegetables, raw fruits and vegetables, add cereals to it, add seeds to your diet. You can have each and everything, but in a very moderate amount, in a very limited amount. So eat the healthy food. God's pharmacy is the best pharmacy that you can have.
Okay, thank you so much, Miss. Thank you.
Welcome.
So our next speaker, renowned guest speaker, Associate Professor Dr. Atif Amin Beg. He has joined us from University Sultan Zainul Abidin, and I would love to welcome Dr. Atif Amin Beg.
Assalamu alaikum warahmatullahi wabarakatuh. Fahim, can you listen me?
Yes, I'm listening. Yes.
Alhamdulillah. Allahumma laklam to come antalu alhamdulillah. Well, I'm going just want to share my slides first. So after that we could just start things. I would like to request some of the very important participants here to just if they can switch off their mic for a while so that other people can also listen properly. Okay, so first of all, Assalamu alaikum warahmatullahi wabarakatuh, and I would like to really acknowledge the branded methods and their team for giving us an opportunity to being able. So my voice is very low. Can you all listen to me?
Yes, it's clear.
Okay, now my voice is okay. Some of people are messaging me. Can you listen to me?
It's clear, sir.
Hello?
It's clear now.
Okay. First I would like to acknowledge Brandon Mathers and their team for giving us an opportunity to bridge actually different people in this very vital topic, which is normally not considered to be discussed. So I would also like to acknowledge and really thanks Professor Dr. Muhammad Ismail Noor, who is basically the president of Malaysian Obesity Society, and I'm too happy that he has joined us with his all concerns, and I feel honored that he is here with us today, and he is one of our mentors. Basically, I started as a neuromuscular disorder specialist, but when I joined one of the universities, I was told that I have to work with obesity, and there how actually I met Prof. Ismail also, some other people, and I actually went into the obesity research since last more than 11 years now. So what we have come up with is a Malaysian Obesity Bank. We assume it to be the holistic approach. So before we move on, I will request all of you, if anyone want to be our member or collaborator, you can just scan the barcode on the left, sorry, the QR code on the left. And if you want to just visit our Facebook page, it's on the right side. You can just scan it, or we can also give you later. So I move on. My first question, after listening to all the respective speakers, starting from our respected Professor Dr. Mahadeva Rao, Dr. Maya Twin, she explained a very brief baseline physiology, followed by Dr. Zareen. Dr. Zareen just mentioned me, she got a patient and she has to rush to the OPD. And then we got Dr. Ayesha, who explained in a very nice way, especially from from her personal point of view. Fahim, you want to say something? Dr. Fahim? Hello, can you listen me?
Please continue.
Okay, so now my question to all of the respected members here who are all listening to all the speakers, would you mind if you can tell me in the chat box, what do you think, what kind of obesity you have? Will you just it's a metabolic obesity, it's a apple shape, it's a Android shape, whatever you think, and you can just write in the chat box. We will see like what outcome we got out of this talk actually. Can you really estimate your type of obesity or not? Well, so some people have no obesity, mashallah, but the people who have obesity, please write it down. So what we are going to proceed now is to my talk, but in the meanwhile, I will be just looking into the chat box. So very important thing which comes to our mind when we discuss about obesity, it's a pear shape, it's an apple shape, or we call it android, or we call it genocide. Some people call it even gynecoid. So it's a genocide. So what we want now all of you to think is from another perspective, which is basically the body fat distribution kind of thing. So I want all of you to think from this point of view, like what if you have obesity or you have a fat deposition, Not even, we are not discussing anything right now, only the fat deposition. So what do you think, what kind of fat deposition you have at this moment? So this is something very important which we need to bring into the mind of everyone. It's not only about the amount of fat or amount of the type of weight, but it's all about also the fat transport, how the body fat transport in your body. Secondly, we also need to consider if it's the body fat transport is not being properly metabolized or not being properly regulated, the deposition will also be abnormal. So we have to think from another point of view now. So we move on to our next slide. Yes, we assume obesity to be heterogenic. What it means that it has different kind of perspectives. It could be what we call it could be it could be because of the psychological status of a person. It could be because of biological influence. It could be because of food and energy disbalance, which we have been discussing since our symposium started, and could be because of physical inactivity or physical activity. So we do have a complex events of in the environment going on, which actually also regulate these four things altogether. So there, what we considered is a heterogeneity of obesity. So this need to be considered always, and for dealing with the obese patient. Yes, now we will put the things in a different way. We are coming from the genetics point of view. So what about the genetics of obesity? There's so many studies which has been conducted in the past, and we found, for example, the biological parents, for example, the people who have the biological parent who are obese, these children, they are 6 to 8 times more prone to get obesity as compared to biological parents who are non-obese. Similarly, there are so many other genes involved in different kind of lipid metabolisms, in different kind of fat transports, which are linked basically with obesity, or any of the mechanisms or processes which are involved in obesity. For example, the genes involved in the transport of the example triglycerides. So for these all genes are being regulated through a complex mechanisms. We are not going at this moment in this talk into that mechanism. It's just an overview what actually we are into. So this is another very important slide, which is linking the entire anthropometry or your physical makeup with a specific genes in your body. For example, BMI is associated with this whole list of genes, which is mentioned in this table. Similarly, we have waist circumference, we do have the waist hip ratio, we do have the weight. So all of them, they have a different, the scenario when we link them, and they are associated with different characters and different proteins and different genes. Okay, well, now what we want actually, we want to come up with a nationwide anti-obese strategy. What we found when we are going, when we were going through different, for the last 10 years, 11 years, we found the people who are around us and the people who have been working in the society, they're doing quite a lot on the nutritional aspect. But actually, what is happening, the person goes to the nutrition, and like when they discuss about their basic parameters, clinical parameters, we just give them a very good diet plan, all those kind of things, like what Dr. Ayesha has just mentioned, mashallah. But the issue was, we put the things in a way in which it is for a long run, and in which it can be bring to the community, society, and yes, also especially to the whole nation. So what we came up, we have the entire scenario, and we put our entire the strength in basically identifying the cause of obesity first. So unless and until we cannot identify the cause, we cannot treat it. So after identifying, we are targeting the treatment part, and after that we are targeting the prevention. And yes, the most important part was to we put it now from the opposite way around. If we want to prevent this obesity, we have to make the people who are healthy to be aware of what obesity is, what are the reasons a person can get obese. So we are also doing the awareness session. We are also teaching the people around like how to control the obesity. Yes, even though in our team we do have some of the people who are obese, but yes, when we look into the genetic elements, we found we just couldn't stop them, but we can avoid their the different phenomena. We still can help them out. So what we are more into looking for huge fundings now. we are looking into a human capital and in identifying the factors which have different treatment plans and the prevention protocols. So this is our whole strategy, and yes, for sure, it can only be workable with a very good team. Well, this is when obesity become globalized. Now the term has been changed to globesity. So it has been shown by WHO in 2014 that the prevalence of obesity in men is more than 25% all over the world. So the next map is already out, but I was unable to access it last night, so I didn't put the slide here. So according to that map, now it's 31%. It's getting very high now. So looking into the female prevalence of obesity in women, it is basically also more, nearly 25% plus. Now it's 37.1. And especially for the participant from Pakistan, just let me try to add in something that in 2015, the data from NIH, which showed that the obesity was 26.8% in females. Now it's 31.6% in females in 2016. Only within 1 year. So the 2015-2016 was quite a difficult year for Pakistan with respect to obesity. So now another very important thing, if you want to treat obesity, if you want to avoid obesity, what will be the best thing which the country will get out of it? Remember that if anybody is having obesity, either because of obesity, the person is going to directly have some health issues, and there is a cost of healthcare in every country. And the country has to bear that cost in majority in all the countries. Or even if the individual cost has to bear, make sure it has actually to be through the country and through the society. So the cost of economical cost of obesity is very important to consider. Indirect cost is there when you have a low esteem or you have low emotions, you think yourself negative, all those kind of things which are associated with obesity. So these all things can actually also affect a lot in obesity basically. So, now we move on to the next slide. Okay, now this is the economical cost of obesity in Malaysia. If you consider the ASEAN regions, which is in Southeast Asia region, you will find something very interesting that Malaysia is bearing the maximum cost to avoid obesity. The economical cost of obesity in Malaysia is 19.36%. As compared to the other countries like Indonesia is at second level, then we do have Singapore, then we have Philippines, and then Thailand and Vietnam. I hope nobody from Philippines here, otherwise they're going to correct my English here. Okay, now you must know the rule of the game first before you play. If you don't know the rules of the game, you will lose. So the rule of the game for obesity is, number one, proper treatment is only possible if exact diagnosis is known. Number two, prevention is better than treatment. So what Malaysian Obesity Bank is working on is basically working on these two rules. We basically define the obesity first before we actually prevent, or we actually treat it or prevent it in our patients or in our obese subject. We will not call them the patient because majority of the cases we are getting the obese who are metabolically healthy. Try to understand, metabolically healthy, or they're genetically healthy, or they're physically healthy. So we call them the obese who are healthy basically. They're not the patient unless and until they have some secondary disorders. So the look into the social factors in obesity. Normally we consider that obesity basically obesity induce the social factors. So this is something very important. We said obesity induce the social changes or social factors. So it means if you are obese, you have some social factors which are not in the non-obese people. We assume that if you're obese, you have some social factor which are not in non-obese people. On the other side, why not we put it in a different way? We said that these social factors are the reasons of inducing an obesity. So they're two total reverse things. So it means if we are trying to say, if we remove those social factors from the life of an obese person, it means they have a very high chance to reduce the BMI or to become a normal individual. We are talking just only about the social factor, not any kind of other factors. Yes, we ought to consider other genetic factors after this, but consider right now we are into the social factors only. Well, so this is the prevalence of obesity in Malaysia. I'll not go through the entire table, but looking into 2015, it's basically it's rising a high, and last one was basically now currently is NHMS 2017, and in 19 we do have some reports. But focusing on the state where I'm from is Terengganu. In Terengganu, basically, we have 32.8% overweight and 15.2% obese according to National Health and Medical Survey in 2011. But interestingly, recently with our students, these two research and done by our group, we found now it's 27.6% in Terengganu, which is too high, because we remember when we started up this projects, it was only 14 point something. So this is another thing which we need to consider for the future aspect. Okay, well, now, this is about the social factors. These are the social factors which are considered in all the obese people, inclusive of the feelings, body image dissatisfaction, which Dr. Ayesha also just talked a few minutes back, eating habits, dieting behavior, health knowledge, physical activity barriers. So remember, physical activity and physical activity barriers, they're two different things. Then we do have the media influence. The media influence a lot for you to getting obese. You love to eat McDonald's, and you hate to eat vegetables. So those kind of things are there. Religiosity, a person who is religious is found to be moderate obese as compared to the person who is non-religious. This is something very interesting we found in our people in Terengganu. So these are some of the results I'd like to share with all of you. So regarding example, we have normally the obese type 2 kind of people, which then we have the feel low esteem is moderate. Interesting, the body image dissatisfaction is severe in obese people. There's something very interesting. Because of that, even the what we call the obesity regret, like you want to buy something, want to buy two things together, later you regret. So like clothes and dresses, all those kind of things. So these things are very severe in Terengganu basically. Well, now we move on. We do have the health knowledge. We do have the physical activity barriers, which is low here. Media influence is moderate, and then religiosity is moderate. So when we look into all the anthropometric values, whatever we got for these for whatever we got for all of these subjects, we found basically the eating habits and the physical activity barriers are the most significant in Terengganu. And it's true when we look into the habits, when we look into the physical activities. Yes, it's really true. They have the issue with these two things, and now we are working out and we're trying to help out the people in our region here. So now, basically, because of these all results, we came up with one of the application is called Obesity Socials, in which any of you you can just download it, and after that you can just fill it out, and it can tell you as a person what are the social factors which are the reason for making you obese. So this is something very, very important. So similarly, there's some other factors. For example, some people assume smoking to be one of the factors. Okay, but yes, we assume smoking is not one of the factors to be obese. But looking at the homocysteine level, which indirectly affects the metabolism, yes, it do affect a little bit, but it's not significant and considered not to be under social factors. Okay, now we move to our next thing. We came up with a very novel anthropometric index. It's called AS index. So what it comes, because what happened, the BMI can give you an idea of overall fat mass, but it can never differentiate, what we call the lean mass from the fat mass, which is the main factor in body fat distribution. You remember the first slide I showed you the type of obesity. So we said it's a genocide. Sorry, the spellings are wrong here. It's a genocide, android obesity, or barrel shape obesity. Genocide is pear shape, android is apple shape, barrel shape is a barrel shape. So we came up with this application after going to nearly 1800 samples. And this is basically, we assume now currently we are working on DEXA, which is one of the radiological technique, and it is very costly. So we are replacing DEXA with this our small app, which can tell you the body fat distribution in a very nice way with respect to the lean mass and the fat mass. You can download it from Google Play Store, and you can see for yourself, and if anything you can refer back to us. Well, so coming to the pathogenesis of obesity, something to summarize all what the respective speakers have talked by now. obesity could be inflammatory. Yes, you will be amazed to know that obesity could be inflammatory. The reason of obesity is inflammation, basically, not the diet, not the fats. The reason of obesity is inflammation. So if you remember, we have the tissue necrosis. In case of tissue necrosis, whenever we have the hypoxia-inducible factor 1 is induced. So when it is expressed, it activates NF-kB and TNF-alpha under our skin, the tissue, in case of tissue injury. Same mechanism is used in case of obesity. When in the adipocyte, we have HF2, 3, and 4. What happened when somebody eat a lot of food, this food enter in the form of fat, vacuole, whatever, it enter into the adipocyte. Once it is inside the adipocyte, the cytoplasmic nuclear ratio will change. You don't have much space, and that result in hypoxia. When the hypoxia is there, this hypoxia induce basically the expression of HF1, and this HF1, when it activates NF-kB and TNF-alpha, that is the inflammatory markers, it will actually attract all the interleukins, cytokines to basically towards the adipocyte. And these adipocyte, after they pick up all these interleukins and cytokine into the adipocyte, they start getting inflamed and start getting big. That is the reason in the microscope, when you look at the adipocyte of a obese person, you'll find a small fat vacuole, but a big adipocyte, which is empty, which is basically a swelling. So what is happening in obesity? Basically, we don't become big. Majority of the cases, we actually swell. Our body is swelling, basically. So this is the entire mechanism of obesity. So what happened other way around? It could be from the inflammatory point of view. It could be from the diet induced, what I just mentioned, if the diet goes in. Third thing is the energy hemostasis. If one of the slides from Dr. Zareen and Dr. Maitrin mentioned is the energy hemostasis. Yes, could be. If energy hemostasis is there, again, the molecules, macromolecules and micromolecules with high energy or a high delta G, they will be again basically stored back into the energy storage depots. And yes, adipocyte will store its own molecules, and this will also give rise again to the inflammatory obesity. Or we are trying to say obesity term has been slowly changed to inflammatory obesity, and now all this together will sum up to be a metabolic obesity, what we are discussing today altogether. So this metabolic obesity is not that easy to be solved when you are saying one person is coming to you as a nutrition and the person is obese. Well, you have to look into its inflammatory markers, maybe. You have to look into its level of diet. You have to look into the social factors. You have to look into the epigenetic regulations. Yes, the genetic is there. We cannot change the genes after, the person is born. But yes, we can still, control the level of expression of those genes through our nutrition. Well, so this is the same thing I've just explained. So this is one of the example I want to show. We got many of our samples in which the issue was this VEGF. VEGF stands for vascular endothelial growth factor. So this is the factor which actually synthesizes your capillaries actually, and it is involved in angiogenesis, which is important for our health. So what actually is happening? Remember, when any person is going to have adipogenesis, when the fat tissue increase, whenever the fat tissue increase, what happened with the fat tissue? Basically, you also need the capillaries to increase. These capillaries have to be increased to give the nourishment to that specific part of the tissue which is increased. So it means adipogenesis basically drive angiogenesis rather than angiogenesis drive the adipogenesis. So what actually is happening here? If a person is getting obese, maybe because of the inflammatory response, because of the diet induced, or what we are saying, the metabolic obesity, what actually is happening, the adipogenesis is still there. But if there is a mutation in this VEGF, vascular endothelial growth factor, what will happen? His capillaries will not form properly. So when the capillaries will not form properly, what will happen? In this respective case, this person will be moving more towards diabetes or cardiac heart issues. This person will be moving more towards CHD. If the gene is normal, then the obese people, they move more towards diabetes. So this VEGF is one of the rate limiting genes and molecule for basically differentiating, the diabetes versus CHD in case of obese people. Yes, the other things coming in, like what Prof. Rao has just mentioned in the start of the lecture, was systematic insulin resistance is there, hypertension, heart disorder, but the baseline is VEGF mutations, which we have to consider. Now, this VEGF is one of the main factor to basically control the level of leptins and leptin resistance also. So this is one of the studies from one of our student. An example, we come up with these kind of data. For example, this is all our some of group our samples, obese versus non-obese, and we found that in these people, waist circumference, hip circumference, fat percentage, all these things are basically highly significant. And yes, we have nothing to do except we have to explain them and we have to talk to them to help them out basically. So, so these are some of the other examples in which something very interesting I want to share here. Remember, we are saying the obese should be less physically less active. But what actually is happening here, that our obese subject, they show to be more active than the normal people, actually, normal healthy people. That is something amazing. So they were more active. And when we look at the level of their activation, it was related with the VEGF basically, because these people who are highly active, we found their VEGF was basically normal, not mutated one. So the people who are mutated one, they are less active. The people who are not mutated one, they are highly active. So now we are bringing another point of view, holistic approach. Now how to deal with them at the nutritional level, at the clinical level will be totally different. So the strategy should be totally different at the personal level to deal with these patients. When we look into the more, more into depth, we found in these people who are less active, they have a mutation from C to T in VEGF gene basically. So this is something very, very interesting for all of us to know, because this was something very amazed. And then we move on to the next part. I'm just telling you how we are dealing with the things at the personal level with the patients. So this is basically the genotypic frequency of VEGF polymorphism. We already know now this is the gene involved. This is the mutation involved. We called it RS833061. This is the name of the reference of the gene of the mutation. So when we look into the factor, we found that in 57% or in 34.1% of our people, this is basically homozygous. The rest are heterozygous. But the TT allele is the maximum one. So we found this T allele or T mutation of VEGF is associated basically with obesity in our population. So this is how we are dealing with that, all the stuff, and this is some of the other data. This is then we map our data again and we come up with the baseline reasons, like, okay, this kind of like overall in the population and specific to the person, what are the areas we need to deal with and what are the areas we need to basically explain them and console them, for the future undertakings, inshallah. So I'll just skip this part. Okay, now the other part we are working on is looking into how to control these genes. For example, VEGF, we found this is a region which can be controlled by diet. For example, protein kinase A, any diet which is protein kinase A enriched, we can give to them. And once it is regulated, the people who are mutated, they actually can overcome the problem. So we are bringing that in the diet, any food which is enriched with phosphokinase A activators. So this is how we are dealing with our patients. Well, this is the lean state versus obese state, what we have mentioned: overnutrition, reduced exercise, normoxic versus hypoxic. You can see the big difference, the size, and these are all the molecules which are involved. And we normally, in case of inflammatory obesity, if we don't go for all of these molecules, at least we target the basic interleukin 7, 3, and 6 to see the level. If they're high, we assume it's a very severe inflammatory obesity and deal our patient in the same way. So these are some of the variables. This is, for example, this is our new anthropometric index, AS index, which is considered to be for the body fat distribution. Okay, now, is it possible that if our adipocyte become very big because of hypoxia, can we reverse the chronic cellular hypoxia with intermittent chronic hypoxia? Answer is yes. And currently we have been working on it. Inshallah, we'll get the answer very soon. It is doable. We have tried with the cell culture. It worked very fine. Now we are working on the obese subject. Inshallah, very soon. We are waiting for 1-2 other projects and grants to apply. Inshallah, we'll focus on this one. And actually, I'm also waiting. I start getting obese, but I will also waiting for these results. After that, I'll use these results, inshallah. And I will share with all of you. You can all use this one also. Then we also came up with one anti-obesity drink. Yes, it is too good, but we do have an issue with some of the inflammatory marker in some of the animal models. Actually, 6 of the animal models, when we give to the non-diet restricted animal models with high-fat diet, we got an issue because 3 of them respond in a different way. Maybe the reason could be their genetic makeup was different, but yes, we actually did not market it for now, but yes, we are improving it, and inshallah it will be out in the market maybe in the next 1 to 2 years. So it is covering a lot of issue. It is covering basically the metabolic obesity, especially the inflammatory obesity, and you can try it with and without diet restrictions. And the more interesting thing is you don't need any kind of specificity for your diet and everything. Anybody can take it from any disease. So because it's targeting the inflammatory part of the obesity. Okay, now this is our Malaysian Obesity Bank. The website will be inshallah available very soon. So what we are doing basically, whatever I've explained you, we just go through for every sample, every person, and we go for the personalized level, and then we discuss with them how to handle them. So this is our entire scope, what we are looking into. This is one of the previous slide. Now we have more than 1,800 subjects here. So these are my postgraduate students who work with me till now, starting from Amelia, my first student, and I'm going to get few more students that are joining me. The team will be back very soon, starting from these few people. They'll be joining us very soon, inshallah. And then we are moving in. Yeah, one of the person, Mubashir Munir, is joining us. He's going to work with artificial intelligence. Like you just want to enter, like a person is obese with a waist circumference of this. It can tell you all the possibilities which you need for the diagnosis part, so that you can define the type of obesity. Then we are going towards the treatment and prevention, inshallah. Okay, so these are few of our articles only for this year. So I'll just share a few of them here. So till now we actually come up with more than 32 articles, and we have nearly secure nearly 22 international awards, which are dealing with our different kind of obesity softwares, different kind of products which are dealing with obesity at holistic approach. So this is one of our activity. You can see here, this is because we are going for the community base. This is one of our activity we did in one of the school, in which these kids, actually we deal with them. And this is for this year, actually, I'm just showing for this year. So we talk to them personally for even 15 to 20 minutes. We sometimes go in the morning and we have to come back late night. And sometimes we have to go for 2 to 3 days to the same school, and we discuss with them. And the first phase is we actually psychologically we prepare them. So once we prepare them psychologically for 1 to 2 months, in which we focus on the water intake, we focus on their sleep intake. Somebody was scolding me last night to have a proper sleep, actually. So sleep intake, then we focus on their sugar intake, the basic things, and especially the physical activity. We start with like 6,000 to 7,000 steps per day. And after that, we move on slowly to the next parts. If they concentrate and they're really consistent in following it for like 1 month, then the next part is we move towards the treatment, and we go for their lipid profiles and all those kind of other clinical aspect first. Okay, so this is some of the examples we have been doing. We are going to the community the whole 3 to 4 days, and we're dealing with these new generation, because they are more prone towards obesity with respect to their quality of life, with respect to their the way physical barriers are. For example, using the mobile phones is one of the physical barrier, for example. So there's so many other things which are considered to be the physical barriers. So we're discussing with them, we're trying to help them out. So this is one of the schools we visited last time. Just a few pictures to share with all of you. So then we are looking now for the Malaysian Obesity Bank collaborators and team who are willing to really do something good. Currently, we are helping UMT in Lahore, Pakistan, to come up with a Pakistan Obesity Bank. Basically, the theme is like Malaysian Obesity Bank. We're just trying to help them out. So they're doing quite well, alhamdulillah. Okay, so one of my last slide, actually it's not my topic for today, but I'm just adding in regarding the theme for today, only one slide, even though I was not asked to do that, but just helping it out. One of the key things to remember is EIF4E, which is one of the associated translation factors. When you have the translation, you have in the RNA, you have the tail and you have the cap. Remember, messenger RNA, you have the tail and the cap. And this molecule EIF4E is basically the molecule where all the growth hormones, where all the insulin, all those kind of molecules, all the anabolism actually target, and it actually affect the either overexpression or underexpression of the gene. So my suggestion is the collaborators should move up now. They should come forward and let us target in hypothyroidism and obesity this molecule. We should look into the genetics of this molecule. We should look into the expression of this molecule, and we should target this molecule for the future, and the downstream values actually, because this is also involved in the inflammation. It is also involved in different tumors of thyroid. It is also involved in obesity. It is also involved in protein synthesis. So I think this could be my last slide. So if anybody want to get involved with us, this is basically you just go through this QR code, or this is my phone number, this is my email. You can consult us anytime, and you can see us anytime you want, inshallah. So that is all from me. Thank you so much for listening.
Thank you so much, sir. It was really a great presentation. Um, if anyone has a question, they can unmute yourself and can ask from our all guest speakers.
Thank you very much. I'm Ubashiruni. Thank you very much, Dr. Atif, to arrange and Mr. Dr. Fahim for organize such a very informative sessions for all of us. Thank you very much. Jazakallah.
Thank you, Ubashiruni, sir.
Thank you so much, Dr. Fahim, for joining, and also thank you for hosting this whole event. You've been the very good host, actually. And I would also like to thank again Prof. Dr. Rao, Dr. Zareen, Dr. Mohammed Twin, and especially what we call Dr. Ayesha. And a very special thank to again Prof. Muhammad Ismail Noor for being here with all of us, alhamdulillah. So inshallah, we will be looking forward for the collaboration, and especially we are always open, especially for anyone who even want to join us as a student or even as a collaborator. We are always welcome, inshallah. So any questions you can still you can post to me, or I'm just sharing the first. Somebody is saying they want to have our what we call the QR code. Fahim, if you will give me just 1 minute to share the QR code here. Can I, Fahim?
Sure, sir.
So if anybody want, they can just registered with our My Obesity and also with our QR code, inshallah. So that you can also catch us on Facebook. You can also get involved with us in our future plans in My Obesity, inshallah. So the whole idea is if you want a proper treatment and prevention, you have to diagnose it properly. If you cannot do that, whatever field you're from nutrition, you are from medicine, you're from physiotherapy, you're from as a researcher, you're a scientist, we just cannot deal with obesity with our own approach. You have to be holistic, and you have to basically define the type of obesity first before moving on. Thank you so much, Fahim. So that is all from me.
Thank you so much, sir. If anyone has question, so that can ask. So otherwise, it's over for today's session. It was really a very informative session, and I'm very grateful to all speakers that shared a grateful and wonderful information. So it will be really very helpful for all of us. We'll love to, and on the behalf of Branded Methods, we'll love to invite your. We're very thankful and love to invite you in our next sessions and get some and learn some new things in our next sessions. So thank you so much. I think it's over now, and we'll see you in the next session soon.